Thanks for joining us today. I'm Jim Lawson, ABC's Outreach Development Manager, and I know I've met many of you at the state, regional, or national meetings, or maybe at the universities over the last 14 or 15 years, but today we're going to spend the next 45 minutes to an hour talking about sometimes confusing and misunderstood subject, privileging. We're going to take a deep dive into privileging, what it is, how it's done properly, and maybe how it can help expand your business. So fortunately for you, I'm not going to be the only one talking today. Fortunately, we have a great speaker, my colleague, Steve Fletcher. Many of you know him, CPO, ABC's Director of Clinical Resources, is going to be joining me today. And Steve has a ton of pertinent information to share with us. Now, before we start, I wanted to mention that we have a quiz that you can take after the webinar to earn 1.5 continuing education credits. Please go ahead and get those credits. You're just going to simply click on the Take the Quiz link next to the webinar on our webinar library. It's going to be listed right there. We'll make sure you have the web address also. We also have the slides from this presentation available there. You're just going to click Download the handouts. So ABC has acknowledged privileging for many years. It can certainly be a very viable way to assist you and your staff in running your day-to-day business. Now, Steve and I speak with many O&P professionals, and we often find out there's still a certain amount of people who find privileging confusing. You're not alone. Or maybe they're not aware of what privileging is. So we thought it was time to renew the topic again. We renew this every 2 or 3 years. Now, we're going to discuss and explain exactly what privileging is, who can be privileged, and the importance of how it should be performed and the specific documentation that's required to be compliant with ABC's accreditation standards. We're also going to take a look at some other options for expanding your practice's patient care. So let's start with the basics here. What is privileging? In ABC's Patient Care Facility Accreditation Guide, it states in one of the standards, quote, "You may privilege certified or licensed staff to provide patient care beyond their defined scope of practice under the supervision of a certified or licensed individual practicing within their scope of practice. If you privilege a staff member, your process must be in compliance with the applicable laws based on written objective criteria and under indirect supervision of a certified or licensed individual practicing within their scope of practice." Unquote. Wow. There. I'm glad you understand it now, right? Okay, so don't worry. We're going to break it down for you in a much easier way to understand. I promise you that. Actually, this is a perfect time to bring in my colleague, Steve Fletcher. Steve has years of experience with privileging and has the intricacies of how to do it correctly. Steve, welcome.
Thanks, Jim. It's always great to spend time with you talking about all these important topics. I'm very glad that we are talking about privileging today. Hopefully we can provide some clarity.
I think we can. All right, Steve, what does privileging actually mean?
Well, simply put, it's when a certified or licensed staff member is granted the ability to provide certain items or services beyond their own scope of practice.
Okay.
That's really what it is in a nutshell. Many practices already use privileging in their day-to-day work, but it's important to make sure that it's done correctly and in line with all of ABC standards. It's important that I mention that the supervising professional really has an obligation to ensure that safe patient care is being provided from the certified staff member who is providing the services beyond their own scope, i.e. being privileged. And our goal should be that by the end of this webinar, our listeners will have a clear understanding of what privileging really is and that they would be confident in describing it or explaining it to someone else.
Very good, very good. So who can actually do the privileging? Does it have to be a specific person or someone with certified credential?
Well, let me start with some basic concepts. To use privileging correctly, the supervisor must be credentialed in the discipline that they are overseeing.
Okay, that's important, right?
Yeah, that's kind of a critical concept that we're going to hit a few times over the course of this webinar.
Okay, great.
For example, a CPO, Certified Prosthetist Orthotist, or CO, Certified Orthotist, can supervise the provision of orthotic care. They both have that credential. or a CPO or a certified prosthetist can supervise in prosthetics. But what cannot occur is a CO, a certified orthotist, cannot supervise prosthetic care, and vice versa. A certified prosthetist cannot oversee orthotic care. Another quick example is a certified podorthist. They cannot supervise the provision of any care that's actually beyond their own scope of practice. I'll give you a quick example. The provision of a partial foot prosthesis for a patient that has an amputation that is more proximal than a transmetatarsal amputation, that's something that is actually outside the scope of practice of a certified podorthist. So they cannot supervise that care or privilege someone to provide that type of a device. I think maybe if we go to the next slide, I'll be able to give you even a more of a description here.
Sure, sure.
So this table, as you can see, shows that a certified orthotist, they can privilege either a certified prosthetist, a podorthist, an orthotic assistant, or an orthotic fitter for the discipline of orthotics. The prosthetist, a certified or licensed prosthetist, can privilege orthotists or a prosthetic assistant in
Right.
prosthetics. So the third row there, a certified podorthist can privilege a prosthetist or an orthotic assistant or an orthotic fitter or even a therapeutic shoe fitter, but again, only within the podorthic scope of practice that the certified podorthist has themselves. You'll see there that it has residents and exam candidates listed there. It's listed there in red because they're unique and they don't really fall under this privileging thing. But the one point I'll make now, Jim, is that a resident or an exam candidate, and we'll define those a little bit more as we go, they are not allowed to privilege someone else. They do not have the ability to do that. They
Okay.
have their own sort of set of definitions and standards about their type of supervision. And so they don't really fit into the privileging conversation that we're going to have.
Sure. So let me emphasize this point because we often see people trying to use privileging with non-certified or non-licensed staff. Privileging only applies when a certified or licensed professional is supervising another certified staff member of the same discipline, right? I got that right?
That is correct, Jim.
Okay, good. So let's talk about how we can use privileging and when it's appropriate. So we get asked this question a lot. How can we use the privileging? So let's take a look at this next slide and we can address it.
Let me just reiterate a couple things, we'll make it very clear and show some graphics just to make this really without any confusion. To decide when privileging is the right thing for your business, if you have a certified staff member that needs to be able to provide care beyond their own scope of practice, then yes, privileging is the way you would do that. If that's not the situation, that your credentialed staff members are really only providing care within the scope of their own credential, then privileging is not necessary.
Okay, very good. So Steve, I'd like to bring up why a supervisor would like to make that decision to privilege a team member, which also kind of goes into the justification of the privileging someone. So maybe you, as a supervisor, are with a patient with a more difficult diagnosis, and a privileged team member could provide health care for a patient with a diagnosis that they are privileged in, thus seeing two patients at the same time. So another idea, as a supervisor, you travel between different offices and you aren't always available to provide the health care needed at that time. So privileging a team member could be very beneficial to your business as well as to your patients. It could also be less time waiting for your patients. Am I correct in that?
That is exactly why practices do investigate the whole idea of privileging. I have to say that really to survive in today's healthcare world, professionals are really under pressure to provide more and more care within the same work hours. And so privileging is really a way to see more patients with the same resources that you have.
Very good.
We've touched on this already, but Jim, let's just talk for a moment about the roles of the different people involved in the privileging framework. The supervising, again, practitioner or clinician is the one who is going to set what are the training requirements for the person to be able to be privileged to provide those expanded services. But I have to say, what is that training or experience requirement is not as cut and dry as you might think. There's not a prescribed, you have to do this much education or be trained in this way in order to achieve privileging. How much education and training and the experience needed is really up to the supervising clinician, the practitioner. And so they're the ones that need to make that decision. And it really is, as you might imagine, Jim, dependent on the type of items and services being privileged to provide.
Sure.
The bottom line is that the supervisor must feel confident that the person being privileged has sufficient training and experience in order to be privileged, because that privileging allows them to be somewhat independent. And we'll talk about that level of supervision in a little bit. They have to verify that that person is competent to provide that care. And under ABC's definitions is done under indirect supervision. Again, we'll talk more about that in a moment. But it also includes reviewing the care that has been provided by the privileged person and countersigning all clinical notes for every episode of care that the privileged person is involved in. And I have to stress that the supervisor takes full responsibility for the care being provided by the privileged staff member.
That's an important note there.
It really is. I think that, practices are busy. There's a lot going on. Whenever a business or a practice wants to consider implementing privileging into their workflow, one concept is something that I remind them every time I have this conversation, and that is the supervising credential holder is ultimately responsible for all the care being delivered under their credential.
That's something to really take to heart. So let's go ahead. Now we know what privileging is and who can do it and why we may use it. Let's go ahead and spend a few minutes talking about how privileging is properly done. So I have this slide here, Steve. Let's look at what may be a typical example of privileging. Can you walk us through this?
I'd be happy to. As you can see on the screen, this is just one particular example we'll use as an illustration of how privileging could be done. Before I go through that, Jim, I want to make a sort of separate point because we keep using the term supervisor. I want to make sure that our listeners understand that when we say supervisor, we are talking about that term in the context of privileging, not in the context of employment. What we are not saying is that, the only person who can be my supervisor is my supervisor, my boss, the owner of the business. That is not what we are saying. This is not a supervisor in terms of employment. This is a supervisor who holds the correct credential in order to be able to privilege someone. So I just want to make that point.
No, that is excellent. That's excellent distinction.
So as we look at the different sort of 1, 2, 3, 4, 5, 6 on the screen, it starts with a decision. A certified orthotist, that's CO on number 1, really would like to have a colleague, an orthotic fitter who works with them, would like them to be able to participate in providing custom diabetic shoes and inserts. Well, since that's not within the scope of practice of a certified orthotic fitter, they would have to be privileged to be able to do that work. And so the orthotist, who's going to be the supervisor, has to identify what is the actual training, education, experience needed for this orthotic fitter to be able to learn what they need to know in order to provide diabetic shoes and inserts. That orthotic fitter then would complete some of that education and training. It might be a manufacturer course. It's going to include some level of supervised work experience, and those fittings and evaluation appointments and follow-ups, that's all typically done early on in the training alongside the certified orthotist, so that the orthotic fitter sort of is shadowing, if you will, being trained on all the elements of providing this care. Once that has transpired and that is all in place, then the orthotic fitter is able to start seeing those patients independently. That We have to stress that the orthotist will obviously has signed off that the orthotic fitter has the competency and is ready to provide those services. The orthotic fitter then starts treating those patients, again, under indirect supervision. We'll define that even more. And then at the conclusion of that care, the orthotist has to review the documentation that goes along with that care and countersign the patient record in a time frame that's established by BC, and that's within 15 days.
Very good. Very, very good. So, Steve, another sometimes very confusing part of privileging to a lot of people, and sometimes to myself as well, is the written objective criteria. So let's get into that, okay?
Yeah, I think that's a good place here to try to really describe this a little bit. Privileging really starts with this, what we refer to as written objective criteria. What it is documentation of the training and experience the person being privileged has. In the case we just looked at, the orthotic fitter, what have they gone through? What training and experience have they gone through in order to safely provide those diabetic shoes and inserts? I mentioned a moment ago that it could be a manufacturer's course. It could be just shadowing work experience hours. Whatever the training and experience is, it has to be documented. It cannot just be that the supervising orthotist in our example just decides that they're competent. There has to be something written down that shows that the orthotic fitter has learned how to provide diabetic shoes and inserts in a safe and effective way. Because the orthotic fitter is providing care beyond their own scope of practice, their own credential doesn't cover that. And so this written objective criteria is what ABC would look at to say, well, there is the evidence, if you will, or the proof of how they have been trained to be able to provide this care that is beyond their own scope of practice. Now, let me just continue that the documentation I keep referring to for the written objective criteria that's required, it really can take different forms. ABC does not prescribe very specifically exactly what it needs to look like, but we give some examples. I've already mentioned once that it can be proof that the person has attended a manufacturer's course online that they have completed, and they show proof of that to learn about, in our example, diabetic shoes and
Right.
diabetes and how to evaluate a patient and how to measure for the shoes, etc. That all needs to be documented. If the written objective criteria is in-house training, if you will, or even in-services that are done at the business, then that has to be documented in the personnel file of the person being privileged. It's basically the written story of what process this person went through to learn what they needed to learn in order to safely provide this expanded care that they are being privileged. Let me give you another example. You may have an employee that's worked for 2 or 3 years,
Sure.
and they've been shadowing and they've been sort of participating in care for patients for a particular type of diagnosis or with a particular type of orthosis. They've been observing, they've been working alongside the orthotist in this example, and so they really have that experience. That is all acceptable if it is documented. And that's where I think sometimes people get a little confused because they say, well, they have had that experience, ABC. They have done that. And so they should be able to be privileged to do that. That's fine, but we would look for the documentation, Jim.
Show me that documentation. Yes.
Exactly.
Very good. Very good. Okay. And you mentioned a specific diagnosis and a specific device to that. Is that correct?
That's right. And I'm glad you mentioned that because what I would use as an example is a very common type of orthosis that's provided out in the profession, and that's an AFO, an ankle
Okay.
foot orthosis. Jim, there are lots of different types of AFOs for a lot of different types of diagnoses and clinical situations. So what privileging is not is a sort of proclamation that the person being privileged can provide AFOs, period. That is not what privileging has to be. It has to be specific to a particular diagnosis and specific to a particular type of AFO. And that is what the documentation should show. Let me give a quick example. A common diagnosis that we see in the O&P profession is what we refer to as PTTD, posterior tibial tendon dysfunction. This
Yes.
is a particular type of a condition where a person has a very collapsed foot and ankle. And there's a very common type of AFO that is prescribed for this diagnosis. That's a good example of if a practice sees a lot of those patients and they need to be able to privilege one of their staff members to be able to see that type of patients, then all the written objective criteria needs to be specific to how did that person learn about posterior tibial tendon dysfunction, what it is, how it clinically represents, and how you treat it. And then what type of orthosis is typically used to treat that, and then how that is evaluated for, what measurements or impressions are taken, how that fitting is accomplished. All those elements of care about that particular diagnosis and that particular device is what the written objective criteria is about. And one more word about that is, let's say that orthotic fitter in our example is privileged to do that particular type of AFO for that diagnosis. That does not mean they're privileged to provide AFOs for a different type of a patient with a different diagnosis. That does not cross over. It is very specific to devices and diagnoses.
Great. Good information here. So how about this, Steve, establishing the individual privileging record?
Yeah, I mean, I guess we'll just keep on using our example of our orthotic fitter here
Okay.
and being privileged by an orthotist. The individual privileging record is a way to sort of organize and track what the person is being trained and educated to provide. It's really what backs up that training that really occurs day to day. Different patients come in, the orthotic fitter sees the patient alongside the orthotist, they participate in that care. This is the documentation, as I've said, that backs that up. A privileging record is really a way to show that the person has gone through this experience and has learned these skills, has demonstrated that they have achieved these competencies, and is detailed on, for example, a record of seeing the patients with that particular diagnosis.
And I think you mentioned earlier, this should all reside in the privilegee's personnel file. Is that right?
That's the best place to put it because, for example, if one of ABC's accreditation surveyors comes to do an accreditation survey, they're going to look at the practice and say, who is providing direct patient care services? Who are the credentialed caregivers at this facility? And when they see an example of this orthotic fitter in the example we're using, and that they are seeing patients that are outside their scope, they're going to ask, well, can I see your privileging documentation? And that's when, if it's all in one place in the orthotic fitter's personnel file, it's really simple for the surveyor to be able to review that and check off on that is being done appropriately.
Very good. Very good. So how about this, privileging record?
Yeah, this what's on the screen there is really just an example. This is something the ABC has as a sample template, if you will. And I think we'll mention where you get that in a little bit. This is just showing, how do I write this down? How do I make this documented? This is occurring in my practice, but I am not sure what's the best way to sort of write down what's happening every day. Well, this example just shows you that this is a person who is learning how to provide diabetic shoes and inserts. They're going through this process. And this is a way to record that to show, well, when did they start? How long has it gone on? How many appointments? And this is not meant to be the end all, Jim. I really want to make this clear point. This is an example. This is just a template. Every practice should really design this what works best for them. Let me add, Jim, if I could, one other point while we're on this slide. I want to make sure people understand that when we use the term a privileging record, what we are not really referring to is what we see sometimes out in the profession, and that is a log. a log of what items has my staff member been privileged to provide. A log, a document, a table that says, let me list out just so that everyone's clear. Maybe it's for the administrative staff up front who are scheduling patients. Maybe they
Okay.
need to understand, and we'll use our orthotic fitter just because it's easier to describe this in this example. They need to schedule patients every day, all day, and a patient calls and says, I need to schedule to get a new AFO. Well, it's helpful for the administrative staff to understand, well, who can I schedule that patient with? Who is able to provide that care? Having a log of, hey, we have gone through the whole privileging process. We have all the written objective criteria documented. All that's in place. So our orthotic fitter can see this patient, and we'll use our other example for posterior tibial tendon dysfunction. They need an AFO. Oh, our orthotic fitter has been privileged to that. I see it on our log that that's one of the items they've been privileged to. So that log can be really helpful to keep track for other staff at the practice. But what the log is not is the written objective criteria. It's just a log. It's just a list of the items and services that someone who has been privileged to provide. The written objective criteria is all the information behind that log, if you will, Jim. So in our example, if the log shows that our orthotic fitter staff person can provide AFOs for PTTD, the log is just a record of that, but the other documentation, either the privileging record that we're looking at or a completion of a course, all of that is really what the written objective criteria is. Correct. So if we move on, Jim, I think maybe we can just recap a little bit. It starts
Sure.
first with the content. What is the specific diagnosis being treated? And then, as you see on the screen, we're using the posterior tibial tendonitis diagnosis because it's an easy one to understand.
Hmm.
So what is exactly being treated? Not only what diagnosis, but what's the intervention? What type of device is being used to treat this condition? The second is the format. Where did the learning take place? When did the learning take place? Who was the person who was either the instructor or the preceptor? And in what organization did they represent? And then finally, what's the process? How did they go, as I mentioned very briefly earlier, from just observing, just kind of riding along, doing a ride along, and we used to say, or shadowing another clinician and sort
Sure.
of observing, to then they sort of progress to, hey, I'm going to participate. I'm going to do a little bit of the adjustments during the fitting for the other clinician, and I'm going to be a little more active participant in the care, to getting to the point where they can independently go through that episode of care alongside the person doing the privileging.
Very
This
good.
is what we need to see.
Okay, this is a very helpful. That's a great slide. So let me do a real quick review of the privileging process. Make sure we have a grasp and I have a grasp of this. For example, if a CO wants a CFO to provide a service outside their scope of practice, the supervising CO needs to make sure that the CFO is properly trained. Going straight through this. The CO also has to verify competency, confirm that all qualifications are met, and make sure everything is documented correctly. So once all of that is in place, the CFO can provide the expanded service under privileging. So this work is then supervised through the indirect supervision of the CO. The CO also has to review the patient chart, agree with the documentation, and go ahead and co-sign and date it within 15 days or countersign. Now, do I have all of that correct in my example of privileging?
You're right on the money there, Jim.
Okay, okay. We're going to have, like you said, by the end of this webinar, we're going to have a great grasp of this. Okay, very good. Well, let's go ahead and take a look at a question on possibly indirect supervision. What would be acceptable options, because you mentioned indirect supervision, of the indirect supervision?
Yes, Jim, ABC has a very defined way of describing what we mean by indirect supervision, and it's what it sounds like. It's supervising someone without being directly or physically right there with them. In other words,
Okay,
you are supervising what they're doing, but you're not there physically watching. So let me give a little bit expanded definition there. What's acceptable for indirect supervision? Well,
right.
being able to be in contact by a cell phone is acceptable. The overarching concept here is that the supervising person has to be available for consultation throughout the patient care process. That's a key thing, and we'll hit that again in a moment.
And that's in
But
real time, right?
yeah, it is in real
Yeah,
time. And a cell phone, what a lot of people I know use is FaceTime if they have
sure.
that type of a cell phone, or any platform that allows for real time, both audio and visual. And that really sets up for success because then you can not only consult with the supervisor, but if needed, the supervisor can see exactly what's going on. But let me not go so quickly to the technology. Just let's go back to what is probably even more common, and that's indirect supervision happening with the supervisor actually being on site, but they're in a different exam room seeing a different patient. That's
Okay.
probably the most common just because it's the most straightforward way to indirectly supervise because obviously the supervisor is available. And if there is really a question that arises, the supervisor can be consulted immediately and they can step away from their other patient and go and see what is going on. And that is really a very successful way of providing that supervision, but not having to necessarily be sitting in the room right next to the person. Again, let me stress that the supervisor must be available for consultation either by the technology we've talked about or being in this building throughout the patient care process. They cannot be unavailable. Person being supervised has to be able to consult with the supervisor during the patient's appointment. It's not something you can just check with them later.
Yeah, no later, no before, no later. It must be real. Okay, good point. Good point. So let me just make a quick overview of indirect supervision, make sure I have it down. The key point is to remember that the supervisor, again, must be available in real-time consultation when needed. They're also responsible for reviewing the documentation, as you mentioned a couple of times, and they need to sign and date those notes within 15 days. So it's important to keep the roles clear here. The supervisor is ultimately responsible for the care provided by the privileged individual, while the privileged individual is responsible for the care they deliver and ensuring their work is properly documented. But here's one other thing. Don't forget, the indirect supervision does not mean no supervision. Just because you may not be on site or you may not be in the room, it doesn't mean that it's not supervised, right?
That is correct.
Okay, so let me throw you a little curveball, Steve. What about state licensure?
Oh, did you have to bring up licenses, Jim? Now, I'm really glad that you brought that up because that's a really important element when a business is considering privileging. First of all, let me start that you've heard us mention a couple times that the person being privileged is either certified or licensed.
Right.
A way of saying that is they have to be credentialed. And by the way, credentialed in ONP, one of the ONP credentials, we are not referring to someone who is licensed, let's say, or certified in another profession. When we say the term certified or licensed, we are meaning they have an orthotic, prosthetic, or podorthic certification or license.
Good.
ABC's accreditation standards recognizes licensed staff members as being equivalent to certified staff members. So an OMP licensed individual meets our staffing requirements. But I really need to encourage everyone that if you practice in an ONP licensure state, you must make yourself familiar with your state's rules on privileging. That is not the same across the country. They're very different depending on what state you're in.
Okay.
Some licensure states will actually permit privileging very similarly to what ABC's rules are, but some do not allow privileging at all or have very strict stipulations that have to be followed if you're going to use other staff members to provide care. You can see on the screen that as of today, there are 15 states that have some form of ONP licensure. Those are the orange states. And then there are some other requirements in the other colored states, the brown and the sort of aqua colored states. They have either an accreditation requirement or a certification requirement, but they don't actually issue licenses. And if you're practicing in one of those orange states, you really need to review the rules and regulations because here's the bottom line, Jim. Licensure trumps ABC's scope of practice and accreditation rules. You can view all these states, what we're showing you at ABC's website. That's abcop.org. And if you just click on state licensure from the homepage, you can see this beautiful map, and all those states with a color are clickable, if you will. And when you click on that state, it will take you to that state's licensure page. And there's many helpful links on each of those pages to all the rules and regulations for that state.
Excellent, excellent. Good information, Steve. Now, but I want to bring something up here. I need to bring this up that there's no confusion regarding ABC certified mastectomy fitters. So a little differentiation here. ABC certifies many disciplines, but the one discipline that has a difference in their rules on privileging are mastectomy fitters. So as you can see on the screen here, mastectomy fitters can privilege, here we go, non-credentialed or non-licensed employee. This is only discipline which ABC's allows privileging of non-credentialed employees. Every other discipline, as Steve has been saying, must be credentialed to be privileged. Am I correct in that?
That's absolutely correct. I'm glad you're pointing this out. And again, it's only the mastectomy fitter credential that can privilege non-licensed or certified people, and they can only privilege them to provide post-mastectomy items and services.
Good point. Good point. Very good. So how about some other options, Steve?
Well, I think Jim, I think we've hit privileging pretty clearly and pretty well. But let's say a business, a practice, they do have some uncredentialed or unlicensed staff members that they really would like to utilize in some way. And so since privileging is really only for the credentialed staff, what do we do with our non-credentialed staff members, and what can we do? Well, don't worry. There is some way to allow those people to participate in care.
Very good.
What it is what we would refer to as support personnel. ABC allows for certain tasks to be delegated to non-credentialed staff members, and we're going to call those non-credentialed staff members support personnel. And there are many tasks that can be performed, but there are some things that they cannot do. So let's take a look at that, Jim. So here's our part of our definition of support personnel. I want to remind you that when the term delegate is used there, that does not mean privileging. ABC sees those two terms as being very different. We've been talking a lot about privileging, Jim, but now we're going to talk about delegation. Delegating is not privileging. It is just having a non-credentialed employee participate in certain elements in the whole episode of a delivery of a service. The tasks that any ABC credential holder can delegate to a support personnel has to be within their own scope of practice. It's the same rules that way. You know, a good example is a certified prosthetist cannot delegate orthotic tasks to a support personnel. It has to be within their own scope.
Very good. So if you remember in privileging, the supervision was indirect. We spent good time on that. So support personnel, the non-credentialed persons, all supervision must be direct supervision, right? So let's go ahead and let's take a look at direct supervision, Steve.
Yes. And as you see here, here's kind of a breakdown of what ABC means by direct supervision. I think it's fairly straightforward, but there's a little bit of nuance. It means that the supervisor must be either on location, physically on site in the building, if you will, or is available in real-time audio or visual technology. Both are required. A little differently when we talked about this for privileging, in that either a cell phone consult by cell was okay or by FaceTime. In the direct supervision world, both have to be available for the supervisor to have access to what's happening. Even if they're not physically on site, they have to have audio and visual real-time connection to the care. And they have to be, again, available throughout the care. And a little higher level of responsibilities, the supervisor has to be able to review the results of care and the associated documentation while that care. In other words, they have to be able to see what is transpiring. That audio visual real-time technology is very important if the supervisor is not physically on site. Again, similarly to indirect supervision, they have to countersign all and date and sign all notes within 15 days of the care being provided. Jim, let me add one other thing that is
Sure.
just a little bit of a nuance, but it's something I just don't want to make sure people get completely sidetracked on. There is a second part of the direct supervision definition that does allow, depending on who is the support personnel, does allow some indirect supervision. I would point people to our website and to go to the scope of practice. If the support personnel that's working for the O&P practice is someone who is, let's say, a licensed athletic trainer or a
Okay.
licensed physical therapist, if they are being delegated tasks, some of that can be done under indirect supervision. That's a little bit of a nuance that's not very common, but I just wanted to mention it, Jim.
But they must need to be certified in a different area, right?
Within the definition, it talks about who can qualify for that
Okay.
slightly lower level of supervision, but that is a possibility. I don't think we need to spend the time on this webinar talking about, but if someone has a question, you're going to tell them how to contact us at the end, I'm
Sure.
sure.
Sure. Exactly. Exactly. So, Steve, can you give us some examples of what that support personnel can and can't do?
Sure. They can provide certain tasks within the provision of a custom fabricated or custom fitted orthosis or prosthesis or orthotic device. Includes intake of a patient, bringing the patient to the exam room, taking vitals, if you will, or taking the height and weight of the patient. They can also help with some of the implementation of the treatment plan. They can perform outcome measures as an example. That's something that a support personnel can participate in for sure.
That could be very helpful. Yeah.
Oh, it's a great time saver, I believe, when the credentialed clinician is finishing up with one patient and there's a new patient already brought back into the room, been greeted, some basic information has been obtained from the patient, from the support personnel, and if it's known ahead of time and they're going to do a baseline outcome measure, the support personnel can perform that outcome measure and get that task done before the clinician even enters the situation. So
Great.
let me get to what tasks that they cannot perform, Jim.
Sure.
And a credentialed caregiver cannot delegate to a support personnel initial patient evaluations or formulations of the treatment plan, and they cannot delegate the final fitting and delivery of the device. One other addition, I'd say, if the patient comes back and they need the device modified or adjusted, if that modification or adjustment really is going to change the function of the device from what it was when it was originally prescribed, that's beyond what can be delegated to a support personnel.
Okay.
A
That makes sense.
Yeah, a support personnel can certainly participate in follow up and make simple repairs and do some of that. But if that repair, that adjustment really changes the function of the device, that's not something that a support personnel can do.
Very good. And what is this, Steve?
Well, let me give you a couple examples. And this is where there are some very defined lines of the levels of interaction with patients and the devices that we provide. Here's the first example. As you see, this is a knee orthosis. This is a good moment to bring up that when we're talking about delegating things, we're talking about the care that is mostly involves custom fabricated or prefabricated, custom fitted devices. This example on the screen is actually not either of those. This is an off-the-shelf device.
Right.
And there's a very important distinction that I want to make at this point. Are still in place, but no delegation or supervision or privileging is required.
Okay.
Here's another example of the same concept. This happens to be a little wrist splint. And again, if off the shelf is in the descriptor, it does not require a credentialed person. So really what this means is a support personnel can provide this type of device. Again, all the right documentation, the prescription, proof of delivery, all the instructions are given to the patient. They're still in place, but that supervision and privileging that we've been talking so much about, and the whole delegation of certain tasks, all that is not related to provision of off-the-shelf devices.
So one thing that those who are privileged and support personnel have in common is how their credentialed supervisors must review their notes, just as those who are privileged and supervisor must review the notes in the patient's charts, countersigning and dating those notes within a 15-day period. But, Steve, for the off-the-shelf devices, this is not necessary. Am I correct?
That's correct. The delegation to support personnel that we've been describing and all the privileging have that in common, that the counter signature by the supervisor is required. Off the shelf is its own thing, and that does not require counter signatures.
Okay, excellent. But I know it sounds like we're beating a dead horse, Steve. We said this many times today, but just as those who are privileged, the buck stops with the supervisor. I just reiterate when I speak to people all over the country about this, as I say so many times, don't privilege someone if the supervisor doesn't feel that they are ready, right? When they sign and date the charts, they are agreeing that their work was completed and they agree with that work and it's been documented. Now, I'd be remiss if I let this opportunity go by without sharing with you some of the options for ABC certifications. There are many certification options for support personnel to explore that don't require a college degree and can be earned while they're still working full-time. So what I'd like to do is kind of review some of those situations here. Now, ABC offers certification not only for practitioners, but also across other several disciplines, including O&P assistants, O&P technicians, fitters, pedorthists, orthotic fitters, mastectomy fitters, therapeutic shoe fitters. Steve has used some of these in examples here today. So each of these roles has a defined scope of practice and a specific level of care they're qualified to provide. Certification requires the appropriate education and or training along with successfully passing one of the ABC's relevant exams. Now, we could easily spend a few hours diving into each of the details of these pathways, but to keep things moving along, you can find all the prerequisites and scope of practices on our website. Steve mentioned it before at abcop.org. I'll show that to you at the end of the webinar also. And if questions come up, don't hesitate to reach out to us. As I said, we're going to share that contact information at the end of the webinar. So what I'd like to do right now is kind of recap some of the do's and don'ts of privileging. Steve, I'm going to ask you to help me one more time.
Okay. Well, let's review really what you can and can't do and we're going to go back to privileging here. First,
Okay.
you have to make sure that you have all the required documentation in place. We can't stress this enough. It includes all the training the person went through. If they completed a specific course, we need proof of that, either a certificate or some documented proof that they completed the course. And that all adds up to the written objective criteria that supports the decision to privilege someone. I want to just say ongoing education is essential. Every ABC credential holder has to stay current, has to do a mandatory continuing education requirement. And I think everyone can understand that we need to stay current with new technology that's introduced, new procedures that are developed over the years. So that really all holds true across the spectrum of whoever is delivering care at your facility. The supervision is another key element, and I think that we just can't stress too many times, Jim, that the supervisor has to be available for consultation and oversight while the care is being provided by the person who is either being privileged to do so or has been delegated some tasks. And talk about that dead horse, Jim. We're going to say it again. The supervisor has to countersign the notes within 15 days. They have to date it and sign it. And we would encourage you that really best practice is to do that sooner than 15 days. It's not a
Sure.
you should wait for 14 days and then sign all the notes. It should be happening as soon as possible, but the outside limit is 15 days. And I think that's something that, as I mentioned earlier, accreditation supervisors do look for, is that countersignatures being done properly. And so one final note, our accreditation surveyors will look for privileging documentation during their surveys. So it's really important that all that be organized and that the practice is prepared to show them that documentation.
Very good, very good. How about some pitfalls, Steve?
Sure. One of the biggest pitfalls, I think, is just thinking you did all the work up front and then just relaxing a little too much. And so I think it's something that all supervisors need to be aware of, and they need to be actively knowing that they are responsible, like we've said, for the care, and that all the items being provided, all the services being provided are really appropriate. And ultimately, Jim, what these rules that we're talking about today are aimed at is protecting the public, protecting that patient who's receiving this care from an O&P facility, that this is a serious obligation, that this is done correctly. Another important consideration for the supervisor is that, if you feel like the other staff member, you have to feel very comfortable that they have sufficient experience and training in order to provide a particular type of care. And if you don't feel that they have it, then you really should hold off. There's pressure sometimes from employers to get people up to speed and get them able to help out with the patient load. But the supervisor needs to take this very seriously. And if they don't feel comfortable that this person who's being privileged really has the skills necessary to safely deliver care, they shouldn't do it. You really have to have a high level of confidence that both the person is competent to provide care, but that the documentation is really clear and complete, and that they have really completed everything they need to be able to be privileged correctly. That's when they can really become a valuable asset to the organization.
Very good, very good. Now, I'm often asked whether residents, we said we'd bring up residents again, whether residents, do they need to be privileged?
No, they do not, Jim. Residents are not involved in the privileging process. And that is because residents are defined really separately within the scope of practice. They have their own supervision structure, if you will, through their residency program, and they are being supervised by residency directors and mentors. And so because of that, privileging really does not apply to residents.
Okay, so the next question I would have then is, so how does this affect residents in the period between completing their residencies and becoming certified? Does it
Again,
affect them?
no, again, the short answer is it does not affect them.
Okay.
The privileging is for credentialed caregivers, as we've said many times. And so someone who's in this status as an exam candidate has not achieved a credential yet. They have their own sort of rules. The best way I found to describe this is that exam candidates have their own definition in the scope, and they continue to be supervised by a certified or licensed practitioner, similar to how they were supervised at the end of their residency. It's basically an extended period of time where the person's considered like a resident, where they can, under indirect supervision, provide all care, but then the supervisor is still responsible for overseeing that care and countersigning all the notes.
Excellent. Steve, you have given a plethora of information. I appreciate that greatly. I hope this webinar has been informative and has helped you and with your privileging practices for all of the listeners here today. Remember again, to receive your 1.5 CEUs for this webinar, go ahead and click on the link under the webinar in our webinar library to take the quiz and go ahead and receive your credits. I'd also like to remind you that all of the information that Steve has been talking about all day long, everything we've been discussing, can be found at ABC's website, abcop.org. Make sure you have that in your bar on your laptop. Plus the contact information for all of our staff members there too. That's pretty important there today. So speaking of staff, if you have any questions about how privileging applies to your practice, you can reach out to our accreditation team at accreditation@abcop.org. Plus, if you have specific questions about scope of practice, state licensure that Steve mentioned before, or how to certify personnel, support personnel, you can reach out to our professional credentialing team at certification@abcop.org. And of course, as always, I'm very happy to answer any questions you may have or get the right team member to answer those questions. This is my contact information. Feel free to reach out to me, Jim Lawson, jlawson@abcop.org. I'd also love to hear from you. If you have any suggestions for future webinar topics that I can pull Steve in with me again, just go ahead and email me. Steve, I'd like to thank you so much for joining us and giving us all this invaluable insight and examples. Any last word you'd like to have for our listeners?
It's been a pleasure, Jim. Thank you for the time. I know that we got into a lot of detail about privileging, but I'm hopeful that we met our goal. People now have a clearer understanding of what is required and what can be done and what cannot be done.
Once again, I'd like to thank you for joining us, all of the listeners to the ABC's webinar series. Don't forget, go ahead and take that quiz. Get your CEUs. You need them, so get them. Have a wonderful day.